Good afternoon, ladies and gentlemen. It's my great pleasure to welcome you to the webinar, which is organized in a joint action between the European Reference Kidney Network, International Pediatric Nephrology Association, and European Society of Pediatric Nephrology. The topic of today is steroid-resistant nephrotic syndrome, an update from the IPNA guideline. As you know, this topic is really very important in our daily practice, and the guideline itself is very extensive. So we decided to split highlighting this guideline in two lectures. The first lecture will be presented today by Dr. Marina Vivarelli from Rome, and the second lecture will be on November 12th and will be presented by Dr. Agnes Strachman from Germany. So remember this date, November 12th as well. My name is Helena Levchenko. I am a pediatric nephrologist from Belgium, and I will moderate this webinar out of my office in Leuven. Let me introduce now our speaker, Dr. Marina Vivarelli. She's already very famous. She is a staff physician in the Division of Pediatric Nephrology in Bambino Gesù Children's Hospital in Rome. She was specialized in pediatric rheumatology in Rome, and she also did the research fellowship in Harvard Medical School in Boston. And then her interest turned to pediatric nephrology, and she started her career as a pediatric nephrologist in the division under the leadership of Francesco Emma. However, her interest has always been and is devoted to the immune-mediated diseases. So she's a real expert in nephrotic syndrome. She particularly discovered their special role of B cells in the pathogenesis of nephrotic syndrome. She participated and also designed several important clinical trials in nephrotic syndrome. She's also interested in complement-mediated diseases, and we are really happy, Marina, to have you as a lecturer of this webinar. So the floor is yours, and we're eager to listen to your talk. Dear attendees, as you know, you can ask the questions during the whole webinars by putting the questions in the question window in your panel, and there will be also some questions for you at the end of the webinar. So please listen well and enjoy this webinar. Thank you.
Good afternoon. Thank you so much, Elena, for the lovely introduction. So this is Marina Vivarelli. I am speaking to you from Rome, Italy, and I have the privilege and great honor of presenting the new guidelines that have been prepared by IPNA in collaboration with IRCNET on steroid-resistant nephrotic syndrome. And again, as Dr. Levchenko pointed out, this is the first part of a two-series of webinars. The second one will be on November 12th and will complete the sort of overview of these new guidelines. So without further ado, we all know as pediatric nephrologists that nephrotic syndrome is something that we struggle with a lot. It's a disease that has been known since the 1500s, and that is characterized by giving swelling of the entire body to children due to the loss of protein in the urine. So when we find ourselves in front of a child with this feature, we know very well what we need to do. And what we need to do is give them glucocorticoids. And we know that with glucocorticoids, a vast majority of these children will respond beautifully, and they are defined as steroid-sensitive nephrotic syndrome. However, a smaller percentage instead will not respond, and they are defined as steroid-resistant nephrotic syndrome. And these two conditions that are part both of the spectrum of nephrotic syndrome are really very, very different. They're very different, first of all, in terms of prognosis, because we know that as long as a child has steroid-sensitive nephrotic syndrome, he or she may experience multiple relapses, but his renal or her renal function will never be impaired. Whereas when we're talking about steroid-resistant nephrotic syndrome, we have a whole different level of complexity and of severity, because these forms can, in a very variable percentage of cases, it depends very much whether you have a genetic form or an immune-mediated form, as we will see in more detail, but they can certainly lead to end-stage kidney disease and to the need for renal transplantation, and some of these forms may even recur following renal transplantation. So steroid-resistant nephrotic syndrome in children really isn't a single disease or a single clinical condition. It's a definition that we give a whole variety of different diseases that fall within this definition. So first of all, it can be either monogenic or familial, the so-called genetic forms of steroid-resistant nephrotic syndrome, which are secondary to mutations in genes coding for different proteins within the podocyte that are altered, leading to proteinuria. Instead, there are a whole variety of forms of SRNS that are immune-mediated. In these forms, you have B and T cells in some way, we don't know exactly how, making a glomerular permeability factor, which injures podocytes, leading again to the to the loss of protein in the urine. And we don't know much about exactly how this happens, but what we do know is that in these forms, immunosuppression can be, in a vast majority of cases, very effective. So genetic versus immune-mediated forms of primary steroid-resistant nephrotic syndrome are different. First of all, in terms of their evolution, genetic forms will lead almost invariably and often rapidly to end-stage renal disease, to end-stage kidney failure, whereas non-genetic forms will not, or if they will, it will take a lot longer. However, following renal transplantation, if you have a genetic form of SRNS, you're probably not going to relapse. It's extremely, extremely unlikely. Whereas if you have an immune-mediated form of SRNS, your chances are about 50% in primary SRNS, and then, as we will mention later on, in secondary forms, this can be even a higher percentage of relapse post-transplantation. So this to give you an idea of the extreme heterogeneity of the condition. Why is it so important to achieve remission in SRNS? It is for a very simple reason, because even partial remission makes you gain hugely in terms of renal survival. And this is particularly true in children. So bringing that proteinuria down, even partially, if you're not able to do it completely, is extremely important. In terms of gaining years of renal function for your child. And this is very important to keep in mind when you're thinking about how best to manage these children. So the challenges of providing guidelines for management of SRNS are its extreme rarity, its severity, its heterogeneity, the fact that it's not really a single disease at all, as I've tried to mention, and also the lack of high quality data. There are very few randomized controlled trials that we can base our statements on. So keeping this in mind, Dieter Hoffner was given the mandate by IPNA to put together a core group of 18 pediatric nephrologists from Europe, South America, North America, Australia, Asia, and Africa, an adult nephrologist to cover transition, a nephropathologist, and an external expert group with 3 patient representatives and a dietitian. This group designed the first version of the guidelines. Subsequently, there was an external voting panel made of 23 pediatric nephrologists, including representatives from each IPNA regional society, that voted on the single statements until repeatedly, using the Delphi method, until above 70% of agreement was reached on every statement that was modified if necessary to reach this level of agreement. The level of evidence was graded in the way that I show here, following the recommendations of the American Academy of Pediatrics. And it's important to keep in mind that for these recommendations, in a variety of situations, we were only able to make suggestions because we didn't have a high enough quality of evidence. And initially what we did was that we devised 9 so-called PICO questions, so patient intervention comparator outcome questions. And based on these 9 questions, the IRCNET team, led by Dr. Troutman, provided tables of evidence. And it's interesting to see that these tables of evidence, which are listed in the supplementary tables of the paper, comprise 60 observational studies and only 26 completed RCTs and 4 ongoing RCTs. In blue, I have given you the link to the published open access article. So the priorities of the guidelines were the following. We wanted to provide state-of-the-art guidance for management of SRNS. We also wanted to be mindful of different resources and different situations that pediatric nephrologists all over the world will be operating in. And we also wanted this to be not something definitive, but a starting point of a work in progress that will need to be continually improved and updated. We wanted to provide common ground for collaborations and studies, so to create common definitions that can be used for future studies, and also to suggest future lines of research. So with all this in mind, let us start with a definition. So the first definition that we tackled was the definition of nephrotic range proteinuria. And as pediatric nephrologists, you know that this can be defined quantitating 24-hour proteinuria, or quantifying a urine protein to creatinine ratio, or using a dipstick. And I think you'll all agree that in practice, most of us in pediatric nephrology for nephrotic syndrome use the dipstick. But as the panel of experts was together, we agreed that at least once at the beginning of the assessment of a child with suspected nephrotic syndrome, at least one formal laboratory assessment of proteinuria was necessary. If not further down the line, at least at onset, this is necessary. And so the question was, is a 24-hour urine collection necessary to monitor proteinuria? We all know how complicated this is in children. So we based ourselves on a lot of publications from the past showing a very nice linear correlation between 24-hour proteinuria and the urinary protein over creatinine ratio. And based on these publications, we said that no, an untimed, so a spot urine sample can be used, so the UPCR can be used, preferably using the first morning specimen to avoid the confounding factor of orthostatic proteinuria. And it was nice to see that a very recent publication that I put here in red was published in March of this year, reinforcing this and showing rock high sensitivity and specificity for UPCR in detecting both nephrotic range and non-nephrotic range proteinuria. We also put a table with normal values of proteinuria expressed as UPCR for age range, being mindful of the fact that in children up to the age of 3, the normal is a little bit higher. And then we also put a table expressing the dipstick results semi-quantitatively to help people be as precise as possible in assessing proteinuria. These are the definitions that we came up with for nephrotic range proteinuria, nephrotic syndrome, complete partial remission, and relapse. And you'll find that they're really sort of common sense. The only important thing that is new is the fact that exactly we accept urinary protein over creatinine ratio. And we do say that at least once you need to have a formal laboratory performed quantitation of proteinuria to define it as nephrotic. So moving on to the definition of steroid-resistant nephrotic syndrome, even on this, there is no universal consensus. Certainly, there is consensus and clarity on the fact that children respond much more rapidly to oral prednisone at standard doses compared to adults, which can take between 16 and 24 weeks. And that most children who will respond to prednisone do so within 4 weeks. So this is a very old cumulative distribution of time to response that was published in '81 by the ISKDC. And based on this data, the KDIGO 2012 guidelines talked about 8 weeks in order to label a child as having SRNS. However, if you see, following 4 weeks, there isn't really much increase in new children that you detect. So you have to balance the need on the one side to recognize these children early so that you can initiate appropriate intervention, and on the other hand, to make sure though that you don't miss children who will then respond within the next following days or weeks. So the experts discussed this quite a bit, and what we devised was the fact that in reality, if you haven't at least partially responded at 4 weeks, you're probably not going to respond completely within the next few weeks. So we decided to define steroid-resistant nephrotic syndrome in the following way. So you start oral prednisone at standard dose at 60 milligrams per square meter per day, and you evaluate response at 4 weeks. If at 4 weeks your child is in complete remission, you have steroid-sensitive nephrotic syndrome, and it's easy. If there is no remission, if proteinuria has completely not changed, it's easy, you have steroid resistant. However, if you have a partial remission, so the proteinuria is starting at least somewhat to go down, we decided to say that you wait for 2 weeks, and we defined this 2-week period as the so-called confirmation period, in which you strongly suspect that the child will be resistant, but you're not sure. You reevaluate at 6 weeks. If the child has gone into complete remission, you have a steroid-sensitive nephrotic syndrome patient defined as a late responder. If instead he has remained in partial or no remission, that child also falls into the category of a steroid-resistant nephrotic syndrome patient. So what is the initial workup that is necessary to do? So for all forms of nephrotic syndrome, I'm going to go through this quickly. There's a very extensive table called Table 2 in the paper. You need to assess fluid status, anthropometry, pubertal stage, vaccination status. You need to check for infections before starting prednisone. In some areas, you may also need to perform quantiferon and a chest x-ray to rule out tuberculosis. You need to do a standard blood and urine workup, a renal ultrasound, and a dietary assessment. Subsequently, when you know or strongly suspect that a child may have steroid-resistant nephrotic syndrome, you need to implement, so at the moment of the confirmation period, a whole variety of different, more detailed investigations. First of all, you have to look for clues of cause, because as I mentioned before, SRNS has many different causes, and this is important to identify in order to manage them appropriately. So first of all, you have to rule out secondary causes, mainly infectious, parvo B19, CMV, Hep B, HIV, malaria, neoplasias such as lymphoma, and other systemic diseases such as SLE or sickle cell disease. You then have to also look for genetic forms. And the two main things that you need to do for looking for genetic forms are family history. So you have to ask for consanguinity and for family cases of renal symptoms such as hematuria, proteinuria, CKD. Also extrarenal symptoms such as deafness, which can point towards Alport syndrome, or nail or knee dysmorphias, which can point towards nail patella syndrome. In terms of a physical examination, you need to look for extrarenal features such as dysmorphia, ambiguous genitalia, which should make you think of a WT1 mutation, neurological sight and hearing that can point you, for example, towards mitochondriopathies. If you suspect a genetic form of SRNS, we suggest to perform also urinalysis of siblings. So the other two things that should be planned or performed during the confirmation period are genetic screening and a renal biopsy. So why do we perform a genetic screening in a child with SRNS? To provide specific treatment when available, for example, with coenzyme Q10, ubiquinone, which can be used for CoQ6, CoQ2, ACDK4, and Leigh syndrome mutated patients. To withdraw useless or harmful therapy, for example, if you have a SMARCA1 mutation, so Schimke syndrome, you have an immune deficiency, you must not be immunosuppressed. To avoid, in some cases, a renal biopsy, if you can have an early diagnosis, for example, of Alport syndrome, and also to provide an estimate of the risk of end-stage kidney disease, which is high in genetic forms, and of the risk of post-transplant recurrence, which is low in genetic forms, to allow screening for dangerous comorbidities, such as if you have a WT1 mutation, look for Wilms tumor and gonodoblastoma aggressively and frequently, and also to provide family counseling for future pregnancies or for intrafamiliar kidney donors for transplant. When should you perform genetic screening in SRNS? Now, there's a beautiful talk that was given in 2019 by Olivia Boyer on all of these aspects, which is a webinar that you can look up. But in general, with the guidelines, what we designed was that in all patients with a diagnosis of primary SRNS, you should perform genetic screening, except in patients with a secondary cause, or in patients with so-called secondary SRNS. So patients that are initially steroid sensitive, but that develop steroid resistance further down during their disease history. If you have a low resource setting, you should give, so you can't perform genetic screening in all patients, you should give priority to familial forms, children with extrarenal features, and pre-renal transplant. And especially, you should give priority to very young onset. This is for this reason. You see that the frequency of genetic forms per age group varies dramatically, being above 60% in the first year of age and around 10 to 11% above the age of 12. Another important concept is how to perform genetic screening. So we know very well that there's a huge amount of different genes that can give SRNS. Table 3 of the manuscript lists what was known up to September 15, 2019. However, the vast majority of mutations is in 3 genes: NPHS2, Potosin, Nephrin, NPHS1, and WT1. So the experts that were called in for this part of the guideline suggested in most cases to perform a panel with next generation sequencing as the most economically viable and rapid form of genetic screening. They also recommended genetic counseling to be able to interpret the results for the patient. And they also suggested if there's a very clear clinical phenotype that indicates a specific genotype, such as nail patella, to look for specifically only that gene. In terms of renal biopsy, so we know that in children with SRNS, there are 3 classical pictures that can give the podocytopathy that we find. So minimal change, FSGS, and DMS. And we know that both a minimal change and DMS are a spectrum leading up to FSGS, which is the terminal renal lesion. These are more or less the frequencies of these 3 lesions. However, what we need to be mindful of is that a child can present with SRNS, and then, especially this 20% is applicable to older children, so above the ages of 8 or 10, say, you can find something else. You can find IgA, membranous, C3G, lupus, TMA, whatever. So why do you perform a renal biopsy in children with SRNS? Mainly for this reason, to exclude rare cases of other glomerular disorders that may present as SRNS, but that then may be susceptible to a specific therapy. To diagnose diffuse mesangial sclerosis, so the most likely WT1 mutation, which requires aggressive screening for the risk of Wilms tumor and gonadoblastoma. And then in general, to assess the status of the kidney damage, tubular atrophy, tubular interstitial fibrosis, and sclerosis. Further down the line, the patient may need, if he receives prolonged treatment with CNIs, also to receive a renal biopsy to assess for CNI-induced renal damage. When therefore, should a renal biopsy be performed in SRNS? It should be performed in all patients with a diagnosis of primary SRNS and not in patients with a secondary cause. We also, though, introduce this considerations. If you have a patient with a strong clinical suspicion of a genetic cause, because they have a familial form or because this child has extrarenal features, especially if he's very young, provided genetic results can be readily available within few weeks, genetic testing is suggested before or in place of a renal biopsy. So in terms of initial management, this is very well detailed in the manuscript, but I did want to mention a few things even here. So supportive measures were discussed by the group. Rather than fluid restriction, which can be useful when the patient is severely edematous, we spoke about balanced fluid intake, taking into account the urinary output. We also spoke about moderating sodium intake with the help of a dietitian. We mentioned the use and the potential help of diuretics and of albumin infusions in case of refractory edema and or symptomatic hypovolemia or oliguria. We spoke more in detail about how to prevent thrombosis in SRNS. It is recommended to mobilize patients, avoiding central venous lines. It is not recommended to use routine prophylactic anticoagulation. Low molecular weight heparin or oral anticoagulation prophylaxis and screening for thrombophilia are suggested if there's a positive family or a positive personal history for thrombotic events, or in the presence of additional risk factors such as central venous lines, severe protracted hypoalbuminemia, or illness or infections leading to dehydration and prolonged immobilization. In terms of treatment, at 4 to 6 weeks from the onset in a child with a diagnosis of SRNS, in terms of glucocorticoids, some groups use IV methylprednisolone boli. This can be done, but we did not feel that there was sufficient evidence to recommend this. The other thing that can be done is that oral prednisone can be gradually tapered on alternate days, and we do suggest stopping in most of these patients within 6 months. And we also provide a scheme for how to taper the glucocorticoids in the paper. RAS inhibition is important because it is proved to improve proteinuria, whatever the cause, and it should be started, if possible, in all patients, either using an ACE inhibitor or using an angiotensin receptor blocker. It's important to aim for the maximum tolerated dose. However, it is important to be cautious of starting it if there's intravascular volume depletion, initial CKD, or hyperkalemia. And it's also important to remember to provide contraception in fertile females. CNIs is the next step, and this will be covered in the next webinar by Agnes Trautmann in detail. So I will now move on to the last part of my talk, where I'll talk to you about the subsequent definitions that we felt that were important to give, subdividing SRNS into categories. So we know that once you've made a diagnosis of steroid-resistant nephrotic syndrome, there are some forms that will not respond to second, third, fourth line of treatment, will progress inevitably to end-stage kidney disease. These fortunately are, especially in the non-genetic forms, the minority. However, there are instead forms that will respond to second or third line agents and will make it across the line to the forms that never lead to end-stage kidney disease. And these in the non-genetic forms are the vast majority. So we will start by defining CNI responsiveness, because CNIs are the first line, when available, of steroid-sparing agent that should be used in steroid-resistant nephrotic syndrome. So a vast majority of children that are steroid resistant, well over 50%, will respond to a CNI. These are the results of a study showing that there's an approach with IV methylprednisolone that appears to be vastly better than using oral prednisone by itself. But in both cases, you see that a substantial, well over 50% percentage of these children do achieve complete remission. So the CNI responsive children are quite a few, and what happens to them after they respond and go into complete remission? So actually, they have quite a good prognosis. And again, in this observational study, the authors show that after 3 to 5 years, they actually do not experience relapses. And in this case, 2/3 of the patients were still on immunosuppression, but 1/3 was not. So we know that children, once they achieve complete remission, even if they were initially steroid resistant with CNI, they then move on to either become patients that have multiple relapses, such as DNS, or they even have infrequent relapses as long as they're left on a steroid-sparing drug, and eventually they can be weaned off all immunosuppression. So how long before you give up on a child with CNI and throw the sponge and decide that they need something else? So looking at this data, you can see that it can take a long time to respond to a CNI. So we have to balance the necessity to give a child the benefit of the doubt and to not withdraw something that potentially can be very helpful with the need to avoid unnecessary toxicity in, for example, an unrecognized genetic form which will never respond, or even in an immune-mediated form, give the child the opportunity to try other therapeutic options. So the experts debated quite a lot on this. And again, a sort of common sense response was come up with. And what most experts agreed on within the core group was that if a child doesn't at least partially respond to a CNI. If a child with steroid-resistant nephrotic syndrome shows no improvement, at least a little bit, at 6 months with a CNI, then they will probably never respond. So we define CNI-resistant SRNS as the absence of at least partial response to a CNI after 6 months of treatment, provided the CNI is given at adequate doses and or levels. So having defined CNI responsive and CNI resistant, as Agnes Troutman will then describe well in her webinar next time for part 2, in the children that are CNI resistant, you are going to try other treatments. And the second line will then lead you to achieve complete remission in some patients and not achieve this, so have a multi-drug resistant child in other cases. So even again, how to define multi-drug resistant. And this is what we came up with. We said that we would define multi-drug resistant SRNS as the absence of complete remission after 12 months of treatment with 2 mechanistically distinct steroid-sparing agents given at standard doses. So this would be a CNI plus, for example, rituximab. Another important definition to give is secondary SRNS. So we know that some children will have steroid-sensitive forms, they'll experience multiple relapses, and then at a certain point, there will be one relapse that will push that child into not responding to steroids, and that child will become secondary SRNS. This is comprises about 14% of the total of SRNS patients, and these forms are particularly dramatic. They represent a clinical unmet need, such as also multi-drug resistant steroid-resistant nephrotic syndrome, because these forms are at very high risk of end-stage kidney disease, and a huge percentage, about 80%, will recur after renal transplantation. So these are really children that it's important to identify and define correctly. So secondary steroid resistance was defined as children with initial steroid sensitivity who in subsequent relapses develop SRNS. I will conclude with the definition that we gave for recurrent nephrotic syndrome post-renal transplantation, which will be covered by Dr. Troutman in the next webinar. We defined it as a child with SRNS presenting post-renal transplantation with nephrotic range proteinuria in the absence of other apparent causes, and or with a renal biopsy showing podocyte foot process effacement. So with this, I conclude. And I invite you to hear the second part on November 12th within the IPNA Clinical Practice webinars. And I also remind you of another webinar organized by IRCNet in collaboration with the ERA EDTA on November 24th, given by Dr. Mueller on the management of autosomal dominant PKD, and a subsequent one organized by IRCNet in collaboration with ESPN on December 1st, 2020, given by Olivia Boyer, presenting the new guidelines for congenital nephrotic syndrome. Thank you very much for your attention. I'll be glad to take questions.
Thank you very much, Marina, for this very clear presentation. It's really very good, I think, that you could reach consensus and definitions and the treatment strategies. I think we have now time for the questions for the audience. So Stephanie, maybe you can project the questions. I will read the questions and then you will have time to vote. So the first question is, the IPNA guidelines suggest that proteinuria to be quantified by urinary dipstick at disease onset and subsequently, by 24-hour proteinuria disease onset and subsequently, by UPCR in the first morning or a 24-hour sample at least once, and the last one, none of the above. So please vote. Okay, I can see the answers. Good. I think most of the people got it right. 83% answered by UPCR in the first morning or a 24-hour sample at least once.
Perfect.
Excellent. So next question, please. Okay, so the next question is, according to the IPNA guideline, a patient is defined as having SRNS when after 4 weeks of oral prednisolone treatment at standard dose. There is no complete remission, the first option, partial but no complete remission after extra 2 weeks, no complete remission after 4 weeks plus minus IV methylprednisolone, BOLA, and the last option is answer A plus B. Okay, so here we have a little bit divided opinions. So 65% of the people answered answer A plus B. 14% answer no complete remission after 4 weeks plus minus IV methylpred, and 15% partial but no complete remission after 2 extra weeks, so after 6 weeks, I think, of prednisolone treatment. So, Marina.
Okay, so this was a little bit of a tricky one. It's funny to see how many people stay with the old definition with the plus or minus methylprednisolone boli, which was abandoned for lack of clear consensus and clear evidence. So the correct answer was both A and B, because in A, you have the classic 4 weeks with complete lack of response. And B, you have the possibility that at 4 weeks you have a partial remission, but at 6 weeks you still have not achieved a complete remission, and therefore between 4 and 6 weeks there's the so-called confirmation period. So both of the first two answers were correct, and I just wanted to try to drive home this message that we did modify and create this new concept that is, you know, potentially controversial and quite innovative, but I think it actually clinically makes quite a lot of sense.
Yeah, I agree. I think that a lot of people have this definition in their protocols, and maybe it's time to reconsider it. Okay. So next question, between 4 and 6 weeks after start of standard dose oral prednisolone in children with SRNS, the IPNA guidelines suggest to start RAS inhibition if possible, always perform a kidney biopsy, search for extrarenal disease manifestations plus secondary causes, and the last answer A and C. Okay, I think we can look at the answers. Yes, so here the majority had it right. So the answer A and C in 66% of the answers.
Good. So here, what I wanted to sort of bring to people's attention is the fact that we did consider it useful to say that you don't always need to perform a renal biopsy, but that in the presence of a system that can give you rapid genetic results, if you have a clear indication that the form is probably genetic, a renal biopsy can be avoided. And I think this is also something important that we brought forth as a potential innovation.
Okay, very good. Okay, so we have another question. Children with SRNS rarely achieve remission, first option. Often progress to end-stage kidney disease, even if they achieve remission. Answer C is can take more than 12 months to achieve complete remission. And the last option is once remission is achieved, relapses never occur. Okay, now we'll get the answer. So here we have also some different opinions. So 10% say that these children rarely achieve remission. 24% thinks that these children often progress to end-stage kidney disease, even if they achieve remission. 66% chose the third option, can take more than 12 months to achieve complete remission, and nobody chose the last option, once remission is achieved, relapse never occur. Would you like to comment?
Yeah, so it's interesting that some people chose B. I mean, it is possible to progress to end stage even if you do achieve remission, but it's definitely not a frequent occurrence. Rarely achieve remission is true for genetic forms, but not for immune-mediated forms because a vast percentage will respond to calcineurin inhibitors. So the correct answer is can take about more than 12 months to achieve complete remission. And the reason for which I put this in is that I really think that one of the important things is to never lose hope with these patients. And especially if you don't think they're genetic, you have a negative genetic screening, to be patient and insist and give them time, because achieving complete remission is super, super important for their prognosis in the long term. And it can take a long time.
Okay, very good. I fully agree. So I think we have the last question. The last question says, defining children with secondary SRNS and children with multi-drug resistant SRNS is clinically relevant because they have a very high risk of developing end-stage kidney disease, B, are at high risk for post-transplant disease recurrence, C, represent an urgent and unmet medical need, and D, all of the above. Okay, so the majority chose all of the above, which I think is a correct answer. Would you like to comment here, Marina?
No, I'm glad that that message came clearly.
So that was a clear message, I think.
Yeah.
Good, very good. I think this was the last question, if I'm correct.
Yes.
Okay, very good. Now we have a lot of questions for you. We have a record number of attendees. We are close to 300 people listening now, so we will see how many questions we can answer, and people whose questions are not answered, Marina kindly agreed to answer by email. But I think there are a lot of very interesting questions, so let's start and we see how far we come. So Dr. Durson, I ask you a specific question. Also, thanks you for a very good presentation. He has a 15-month-old girl with WT1 mutation. Her albumin is about 2.5, 2.7. And he asked, do he need to take a kidney biopsy? And would you try CNI in this child?
So, I mean, I'm not an expert on the genetic forms. I'm more of an expert on the immune-mediated forms, but of course, I'm happy to give my opinion. I don't think I would subject this child to renal biopsy. I would perform very accurate screening for neoplasia, and I would perform the search for chromosomal abnormalities to make sure that the child has normal chromosomes. In terms of treatment with the calcineurin inhibitors, this is a heavily debated point. As you very well know, calcineurin inhibitors can have a protective effect on the cytoskeleton, and there is some evidence of some genetic forms having at least a partial response. I'm not sure, though, that in this context, I would attempt it, honestly. I don't think that the cost benefits would be particularly of benefit to the child. But I want to be very clear that this is my personal opinion, and there may be very good reasons for having a different one that other people may have.
Okay, thank you. There were actually several other people asking about using CNIs in genetic forms of CRNS. I think there was a survey sent by Angel Toulouse by the working group of nephrotic syndrome. Marina is actually also the president of the ESPN working group on glomerular disorders, and the aim of the survey is to evaluate or to find children who got CNIs in genetic forms, I guess, to have some larger series to be able to give an answer to this question, which is, I think, very difficult.
Yes, I think it's something that we need to look into a little bit more clearly, and also to be sure that the patients who do show a clear response actually have pathogenetically relevant mutations and not simply variants of unknown significance. But I know that many of us have had the impression sometimes that some genetic patients can clearly respond, and clearly we have had patients with genetic features, syndromic children that at least partially benefited from the use of calcineurin inhibitors, probably, exclusively due to their effect on stabilizing the cytoskeleton. But, if that can save people years of renal function, then that's great. But we need more information to try to understand when to attempt this and for how long. And at this point in time, we really don't know.
Right. So another question is regarding which CNI do you think is preferred? Is a difference between cyclosporin and tacrolimus?
So there are studies comparing, and the bottom line is that it's difficult to say that one is better than the other. So we didn't provide guidance in the guideline to say that tacrolimus should be preferred to cyclosporin or vice versa. We do suggest choosing based on other considerations, which can be the presence of glucose intolerance or familiarity for diabetes, which would discourage from the use of tacrolimus, and aesthetic reasons, and the risk for gingival hypertrophy and hirsutism, so hairiness, can lead, especially in older and especially in females, towards preferring tacrolimus instead of cyclosporin. And general availability, cost, the formulation, all of these can be considerations, but we didn't think there was enough evidence to say that one works best than the other. Another thing that can be said is that sometimes if a child doesn't respond fully to for example, cyclosporin, but seems to have an initial response, it can be reasonable to attempt the other calcineurin inhibitor that he or she has not yet attempted, and see if that works better.
Okay, I agree. So Dr. Ala Ali is asking, what about IgM or C1q predominant forms? Could be part of the spectrum or to be treated as a distinct entity?
So C1q nephropathy is a different entity. I mean, it can definitely present as absolutely correct with steroid-resistant nephrotic syndrome. Same for IgM. These are, sort of proliferative glomerulonephritides that can present with forms that do not respond to glucocorticoids at 4 weeks. These forms very often do respond then to subsequent, more intensive immunosuppression. And yes, she's absolutely right. They are part of the spectrum. It's, one of the reasons why we do need to perform a renal biopsy.
Good. So we have 2 questions from Dr. Srivastava, who is asking about actually the need of kidney biopsy some patients. So he's saying, for example, if you have 10-year-old girl with idiopathic nephrotic syndrome, having microscopic hematuria and hypertension, is very likely to be non-minimal change disease. Would you suggest renal biopsy upfront or giving prednisolone?
So if I understand correctly, the question is not on whether to perform a renal biopsy at 4 weeks, so upon diagnosis of SRNS, but rather to perform the renal biopsy at onset of the disease.
Yeah, exactly. So the question is actually whether we should wait in all children until 4 weeks after we start prednisolone, or we can select already some patients where we have
Okay.
suspected other form than a minimal change to perform the kidney biopsy before giving birth.
Right. So that is something that was not discussed in the guidelines, but just in general, the rule of thumb that I follow, and I think that many colleagues would agree, is that absolutely yes, if at onset, especially above the ages of 10 or 12, some people put the cutoff at 8, but I think 10 is probably the most reasonable cutoff in terms of age. From 10 up, if you have any sign that makes you think that there might be systemic disease or a different disease from minimal change, in this case you've spoken about microhematuria, we know that nephrotic syndrome, classic nephrotic syndrome, can present with microhematuria in 15 to 20% of cases. But if the child is not severely hypertensive, if you don't have huge risks, especially if, for example, complement is lowered or there's positive ANA, anything that can push you towards thinking of other diseases, it can be reasonable to perform a renal biopsy. It's, however, incredibly difficult in this to give a guideline. I mean, this is clinical experience, looking at all different aspects, taking a correct family history, examining your patient, looking for systemic signs of disease. It's not something that can be sort of written in a textbook and just applied. But in general, the cutoff of 10 years is a reasonable cutoff in which the percentage of children that will have something different from minimal change disease gets to be high enough that you have to think about it. And if you are reasonably concerned that there might be a different diagnosis, it's definitely of benefit, if the child has normal blood pressure and normal platelets and a normal coagulation, to perform a renal biopsy and obtain a precise diagnosis.
Okay, thank you. So another question is from Dr. Sumantra Raut, who is asking if you have given 4 weeks of daily steroid in the child with the first episode of nephrotic syndrome, and the urine dipstick is showing no proteinuria. However, the serum albumin is still less than 3 milligram per deciliter. Can you consider such a patient as steroid sensitive? So when you
yeah, that's a good question. I think you can. I mean, the numbers are put there to provide guidance, but it's also a matter of common sense and of experience. And of course, this is biology and human physiology. It's not, mathematics. So there always are those weird patients that are outliers. But, if the proteinuria has gone down to 0, the serum albumin has significantly increased, the cutoff number, it can be 2.5, it can be 3, it doesn't really matter. I mean, at some point the patient will go above 3, or you have to look for other causes of hypoalbuminemia that are not correlated with the proteinuria. But, if the proteinuria is down to 0, the proteinuria is down to 0, and I would definitely consider that child responsive.
Sure, I think, yeah. Another question is from Dr. Scott Wednerfer, who is asking about the definition. He's asking, secondary SRNS is similar nomenclature to nephrotic syndrome due to secondary causes. Is there another nomenclature we can use? It's a little bit confusing. He's right.
Yeah, he's absolutely right. And actually, I put them close because I wanted to underline the fact that they're two different things and that we have to be careful. I think this is actually the main thing that I think we sort of missed and needs to be perfected of these guidelines. So the term secondary can be used relating to the cause of this SRNS. And in that context, it can be SRNS due, for example, to lupus or to an infectious form. But also in terms of timing, we talk about secondary SRNS in a child with initial steroid-sensitive nephrotic syndrome. So this is definitely a potential source of confusion. The context in which these terms are used can most frequently, allow you to discern, but he's absolutely spot on right that this is something that is potentially confounding.
Good, good. So now we have a lot of questions about treatment. I think treatment options will be also discussed during the second webinar by Agnes, but maybe I can ask some of these questions. So one question is whether we need to use MMF before putting a label of multi-drug resistant nephrotic syndrome.
So we need to use something other than a calcineurin inhibitor. So a multi-drug resistant is a child who has failed 4 weeks of glucocorticoids, failed 6 months of at least, has not received at least partial remission at 6 months with calcineurin inhibitor, and has been given a third option, either rituximab or MMF or whatever, and has not responded to other 6 months of that. So yes, the answer is MMF is definitely one of the options that can be given to define a child as multi-drug resistant SRNS.
Dr. Morani is asking whether mycophenolate should be combined with CNI, or they should be used subsequently when genetics is not available. So it's actually the two questions are, I think, whether these two drugs should be used simultaneously. And another question is, yeah, I think definitely in places where genetic tests are not remotely available, you have to play around with drugs and see how you make the definitions.
Yeah, so question number one, there are different situations in which mycophenolate can be used in combination with CNIs or sequentially, depending on the patient. So we tend to use it in combination exactly if we're trying to add on therapy to achieve complete remission. Instead, in a patient in which we have already achieved complete remission, for example, with a CNI, it can be reasonable, and studies by Jutta Gellerman's group have shown that substituting the CNI with MMF can maintain the child in stable remission and release the burden of the CNI toxicity. And this can be a viable approach for an SRNS patient that is CNI responsive. So that's the first part of the question. The second part of the question, it's difficult when you don't have genetic response, either because you don't have the availability of genetics, or you have performed a panel but it's negative. Essentially, unless you have clear features that point towards a genetic form, so dysmorphia, extrarenal features, a strong family history, et cetera, you have to presume that that child has an immune-mediated form, and you have to try to achieve at least partial, if not complete remission. But these are the most difficult patients to treat, and there are situations in which taking a decision is tough.
Okay, very good, Marina. Maybe one last question is, several people actually are asking whether it makes sense to switch from one CNI to another one when child doesn't respond, for example, to cyclosporin, to switch to tacrolimus, or vice versa.
Yeah, I think it does, especially if you have a partial response and you've given at least 6 months of an adequate level. It can be a good idea. Otherwise, no. I mean, if you're doing fine, you have to be patient. So if you have the impression that it's just a matter of, holding tight, then you shouldn't switch. I mean, unless you have side effects or significant problems with that specific CNI. The other thing with the CNIs that is absolutely essential, and that maybe Agnes will have a little bit of time to discuss more in detail, is maintaining adequate levels. And this, especially in smaller children, can be really challenging. So, if you've been for 7 months on a CNI, but you've never achieved a decent level, you can't say that that child is not responsive. You just haven't treated him well enough. And, sometimes it's extremely difficult to achieve those levels, but that is absolutely key to response. And this is true both for tacrolimus and for cyclosporin.
Yeah, I fully agree. Maybe the very last question, and then we will have to close the webinar. So the question is whether you achieve the remission with CNI. Do you continue low dose prednisolone or you stop prednisolone?
Yeah, so that's actually a really good question. And we talked about that quite a lot because people do so many different things and there really is zero evidence in the literature. So we felt that we needed to provide a little bit of guidance about this. And we felt that for SRNS, it wasn't reasonable in most cases to give glucocorticoids for more than 6 months. So we suggest discontinuing glucocorticoids even in patients who respond to calcineurin inhibitors after 6 months. And we also provide a suggestion of a tapering scheme that can be employed. Zero evidence, it's only expert opinion, but we thought this was important to provide some guidance.
Thank you very much, Marina. So I think it's time to close the webinar, and I would really like to thank you once again for an excellent presentation and for lovely answering different questions. I would like to thank the audience for attending the webinar, and once again, many questions were not answered because there were a lot of them, and Marina kindly suggested to mail some questions to her. You have her email on the slides. The webinar was recorded and you can find the slides and the recording on the websites of ERCnet and also of IPNR. So thank you very much again. I hope this guidance will be useful for you to treat your patients, and see you or hear you back on the 12th of November for the second part of the guideline. Thank you very much. The webinar is closed.
Thank you very much.